Just a reminder to please be seated as the program's about to begin. Thank you.
Welcome back, everybody. Come on back to the tables. Thanks for visiting with the sponsors and exhibitors. It's great to see all the activity at the tables, and thank you, sponsors and exhibitors, for being here again. It just really makes a big difference. Every year we have this, they come back and say, it's so great to see the variety of services, variety of new medications, and the great people behind the tables helping us out. So one of the tables I want to make sure you do visit today is the California Parkinson's Disease Registry table, otherwise known as CPDR, which is on my mask of choice, if you will. We wear these because back in September of 2020, we held a statewide, national, international conference focused on outreach for the registry. And for all those of you who are people with Parkinson's and have visited your medical care provider, your information is put into this registry, protected, and also used for data analysis. So this registry is a really key tool for public policymakers, for researchers, for pharmaceuticals to know how big, how many, where, what ethnicity, what gender, what age you all are, so we can get more treatment, more meds, more services for people with Parkinson's. So it's a very important project. And I want to introduce the director for the California Parkinson's Disease Registry, Mark Damison. And Mark and I work in the good old state of California bureaucracy together. And all those of you who worked in private sector, or you've worked in nonprofits, or you've worked in the public sector, you know when you can have good partnerships and legitimate and meaningful partnerships, what a difference that makes to the quality of the program. So I'm real pleased to introduce Mark. Mark and Sandy and Tommy and their whole crew have been really strong partners with the Parkinson Association of Northern California, and really been genuine in trying to make sure the Parkinson community is aware of what this tool is and what it can do for you. So I'm thrilled to bring Mark up and talk a little about his credentials, and then let him tell you a little about what the registry is doing today and all the good work that's ahead. So Mark is the California Department of Public Health official serving as the director of the Richard Paul Heman California Parkinson's Disease Registry. And I looked up, I said, who is Richard Paul Heman? He was a very good friend of Governor Brown with Parkinson's, so that's why the registry is named after him. He's leading the development of the newly authorized California Neurodegenerative Disease Registry. So it's expanding, so listen to that good news. Dr. Damison holds a Doctor of Public Health degree in epidemiology from UCLA. I guess go Bruins, kind of? Yeah, all right, go Bruins. He has worked in public health surveillance for 30 years and served as surveillance official for the World Health Organization and the Centers for Disease Control, and joined the Department of Public Health in 2008. And again, I just want to say thanks to Mark and his team for being great partners for PANC, and I think you're going to like his presentation, so welcome, Mark, and great to see you again.
Thank you, Sean. And I want to thank everybody here. I could not have summarized the importance, significance, and purpose of the registry better than Sean just did. So he's now an honorary staff member for the state. Well, he is with the state anyway. But so I really appreciate your time to give you a brief update on the California Parkinson's Disease Registry. So this is how my presentation is outlined. I'm an epidemiologist, a statistician of sorts, so organization is really key. I'm going to first talk a little bit about some legislative history, go into the purpose and procedures of the registry, and then that's going to include a little bit of sort of who does what. And you have, by the way, patients do nothing. I want to put that out there early. We'll give some quick reporting highlights and next steps. So, as I say, starting with legislative history, what Sean just mentioned a moment ago about the Richard Paul Heman, who that was, that the Senate Bill 97 in 2017 established the registry as a pilot. It was only, and that's what it means when it says through the 1st of January 2020, the registry was established as a pilot to see, can we make this work? In the interim, in 2000, that's a typo, my apologies, that's 2018, the registry was extended out further into 2022, and just this last summer, AB 133, Assembly Bill 133, extended the registry indefinitely. That's what it means by remove the sunset date. So what I want to say is thanks to all the support and all the hard work that's gone in, now this registry is no longer that pilot, because it's been shown, as we'll show later, to be very successful in capturing information. Now, the purpose of the registry is, and Sean really summarized this well, enables research to better prevent and treat Parkinson's disease. Now, there's epidemiologic research, and that's where you're looking at the whole population. And I'll show a map later to kind of give an example of what that is. Clinical research that will be able to use this information, as well as health services. And Sean spoke to both of those. Health services being, where do we need to put services to serve Parkinson's patients. We need to know where those patients are so that we can have a better targeting of those services. Now I'm going to go into procedures as to how the kind of the registry works. This is just really brief. I'm happy to talk with you at the table later if you have further questions. So the data comes in it's provided by your providers. It comes to the state where it's analyzed epidemiologically, as I say, kind of looking at the population. Epi is over, demos is people, so over the people. And then you're looking at things like socioeconomics, demographics, as well as spatially, where geographically the cases are. Then with that data is shared with researchers who are investigating ways to better prevent as well as treat Parkinson's. As well, we call that together control. So the data is used to control the condition, both to prevent as well as once people have it. The researchers who can access the data go through a very stringent process, which includes what we call an institutional review board, as well as strict privacy procedures. And I want to make a point here that no data will be released without these confidentiality procedures. Now, what type of data is being collected? And there's really 3 buckets. There's not a lot of data that's being collected at this point, but basic demographic information, the healthcare providers information, and then basic clinical information. Just simply really the diagnostic code. Now, one thing that you'll probably be interested in is what about privacy? HIPAA is the Health Insurance Portability and Accountability Act. And if that sounds like word salad to you, it just really means that that's a federal law requiring any data collected but for public health purposes or in any medical purposes to be held strictly confidential and never shared beyond what is absolutely necessary. So there is not an informed consent. So you did not, if your doctor reported, there is no process where you signed something. As I say, strict confidentiality procedures are maintained on all the data at all times. There's encryption that happens, so not only do we have confidentiality procedures that no one else can access the data except those who are allowed to, but within our infrastructure of keeping the data, we use all the most advanced electronic protections. One last point is no data is shared with DMV or really anyone else unless it's through those strict procedures for research purposes. So a little bit, just going quickly through the process, answering some questions you may have. The data submission happens from the health provider. As the question here says, you do not need to do anything. You don't need to send your data. The next 2 pieces are around what we do with the data to make sure that we're really getting something accurate. As you know, as the old saying, garbage in, garbage out, we're making sure that this data is good and that it will be telling a story that is truthful. We have data is a big focus for all of government now under President Biden, but that's also under the state of California as well. As I say, there's quality control, and indeed deduplication is part of that. We make sure that we're not recounting somebody. As I say, there's also very strict protocols around data use. The data are used to examine things like incidence and prevalence. And so I want to speak now to some of the results, and this is really exciting. I want to say this is the first time we have presented something like this. But what we're showing here is really the total number of records, because the data is coming to us electronically, or much of it is. We get multiple records for one person. We deduplicate that, and we have reached almost 85,000 individual patients, not records. That's more like, as you see, closer to 500,000. But the team at the Department of Public Health that works with me has gone through a lot of sophisticated analysis to ensure that we've deduplicated those records. And you can see some particular statistics there on the slide. Now, the next slide is, as I say, this describes who is in the registry at this point. What we're showing this by gender and age. As you'll see, the blue is male, the orange bars are female. Along that horizontal axis, you're seeing increasing age. And what we're seeing is what we'd expect. There is more cases at older age groups, also more cases in men. From this, what's exciting to see is that the registry data is really reflecting what we know from other research studies that have looked at the distribution of Parkinson's. So this helps to validate and give us trust in the information. Another picture of the data is this map, and we're developing more of these. Sean was just asking me about that, and we are working toward more information that's more accessible, and maps are very helpful for that. What this is showing is the more red means higher numbers of cases, the blue means lower numbers. This is a county map of California, and what you're seeing is that the counties with the largest number of cases in the registry are those 5 that you have on the right of the slide, and with Los Angeles being the top. Like we showed for the age and gender breakdown, this also gives us trust in the data, because we know that these are also the counties with the largest numbers of people. So this is what we would expect. And as a scientist, when you're really just starting a new registry like this one, what you want to first do is look at your information and see that it just makes sense given what we already know. And indeed, this slide is showing that is the case. Now, the last slide is about next steps. And as Sean said, we have a very close relationship with PANC. So we will be talking with the PANC board and PANC leadership, and we'll be able to know what kind of information would be useful to you as PANC members. And then we'll look at ways to get that out to you before next year's conference, and we'll be back here again. But the points I want to make about next steps are that first we continue to onboard facilities. Onboard means they start to report to us. We've published a data disclosure protocol, and that's what I talked about earlier. It's a fully privacy-protected protocol through which qualified researchers can access the data and therefore be able to discover things about the condition and its epidemiology that was not known before. Another thing I want to point to is that there's this last summer, a bill called Assembly Bill 133, and I mentioned this in the second slide, was signed, and now what this is having us do is create a neurodegenerative registry, which is going to be very similar to Parkinson's and include other neurodegenerative conditions. This will be very important as to increase the utility and the longevity and the quality of the registry. I want to thank you for your time. I always really appreciate and enjoy coming to this conference because of you, really. And my time's up, so I can't say any more. But I just want to say again, thank you.
All right, thank you so much, Dr. Damison. PANC strongly supports CPDR and all the progress you guys are making. So our next session is always so well received. The expert panel is moderated today by Dr. Niklesh Thakur and Dr. Suketu Kandar. They've recruited experts in the field to discuss tackling tough situations. Dr. Thakur is a movement disorder specialist at Sutter Health in Sacramento. His professional interests include movement disorders and specialization in deep brain stimulation for Parkinson's disease, essential tremor, and dystonia patients. In addition to his medical practice, Dr. Thakur has participated as a co-investigator in clinical research studies relating to movement disorders. His personal approach to care involves looking at each patient individually and analyzing every movement to diagnose and treat them most effectively. Every patient is a family member, and he and his team do everything within their power to treat the underlying neurologic condition. Dr. Kandar is a movement disorder specialist and the medical director of the Comprehensive Movement Disorder Program for Northern California, Kaiser Permanente. He completed a fellowship in Parkinson's disease and movement disorders at the University of California, San Francisco. Dr. Kandar works with a team of specialists focusing on Parkinson's disease, essential tremor, and dystonia. He has championed multidisciplinary care using an integrated practice model. He is an organizer for the Triennial World Parkinson Congress and has spoken at courses on behalf of the Movement Disorder Society. Welcome Dr. Thakur, Dr. Kandar, and the expert panel.
Well, I'll introduce everyone.
Yeah, go for it.
Sorry. Thank you. Thank you so much. It's a pleasure to be here. You know, it's so great to see everyone in person. It's an amazing meeting. We've been living virtually for the last year and a half, and this is just a great turnout. So we have an amazing expert panel today, including experts all around, California. And so I'll start with introducing them. First is Cheryl Choi, care partner, caregiver of Jimmy Choi, you heard earlier, American Ninja Warrior. We have Mark Fierro, he's a movement disorder PA and an acupuncturist at Sutter Health in Roseville. We have Lisa Mooney, she's a social worker, UC Davis. And then we have Dr. Stephen Nakano, he's a movement disorder specialist at Sutter, Sacramento, just recently joined us. And then we have Sarah Panasco, she's a neuro PT at Kaiser. And then last, Linda Tretton. She's a neuropsychologist with Dignity Health. So basically how we're gonna do this is, and of course, Dr. Kandar, we'll go over cases. They should be in front of you, and we'll be reviewing them with the panel and how we approach these patients that see us every day in the clinic. And then the second half we'll do answering question after a little break. So I don't know where the clicker is. Okay, all right. So should we? Is the PowerPoint not working or?
No.
Oh,
There we go. We got it.
Okay, all right. So should we sit down with them?
Yeah, that's
okay. All right, so we'll just join the crew here. All right. So our first patient that we have here comes to us as an 84-year-old right-handed healthy female. She has a mild resting tremor in her right hand and also some stiffness in her arms with intermittent cramping
This is
of the right foot.
It's the last slide. We should do the first one first. Sorry.
Oh, out of order.
There we go.
There, maybe you should man it.
When I do that.
All
There we
right.
go. We're starting over.
Yeah, so you can follow around. Sorry about that. So first patient, 68-year-old right-handed male, retired farmer who lives home alone with his dog. And he's noted a left-sided tremor with some imbalanced slowness of walking for the last 3 months. And he had a fall. The dog got in the way and he tripped and he hit his right wrist and he's developed some pain. He also notes some loss of smell, and he's also had, problems with sleep where he just ends up on the floor and no one's around and not really sure what's going on. And so he went to his primary care doctor about the wrist pain, and she was worried about potential Parkinson's because of the rest tremor and walking difficulties. So we'll go through the neurologic exam through the neurologist that was referred to. In general, some loss of facial expression, reduced volume of voice with hypophonia, and just a generalized slowness, or we call bradykinesia. Her motor changes was a little rest tremor on the left side with some stiffness and slowness, but strength was normal, reflexes were normal, sensation was all normal. And then with the walking, he was stooped over a little bit, shortened stride length, some problems with turning, and a decreased arm swing and some imbalance. And so this is a typical patient that we see in our clinic. And so with the panel, I don't know, maybe we'll start with.
It might be best to start with Stephen.
Yeah.
Right? I mean, so you're the general neurologist. You're a movement disorder specialist, of course, but this is someone you're going to see in your clinic. What's going through your mind, and how is it that you come to the diagnosis, and how do you disclose this diagnosis to somebody?
Yeah, and so, as many of you are aware, the diagnosis of Parkinson's disease can be a very scary thing, right? And sometimes you enter into the clinic room with some sort of inkling, and sometimes not. Mask off. Sorry, thank you. And so with that in mind, when I approach a new patient who looks like this, who comes into my clinic room, the first thing is that we have to develop the relationship. So there's a degree of trust that's important there. And so I always tell my patients that finding a clinician that you see eye to eye with is somewhere between finding a spouse and finding a roommate. And so there's a huge degree of back and forth that's required in that relationship, because you have to trust me and I have to trust you. And so finding someone that you see eye to eye with is very important. And so when I'm approaching this patient, the first thing is that, sometimes, even if there's something scary, being able to name the monster gives you some sort of power over it. And so what do we call this thing? And so when I'm speaking with patients, it's important to emphasize that Parkinson's disease, despite where technology is these days with brain scans and lab tests, it's still a clinical diagnosis. And what I mean by that is I sit down with you and I listen to your story and I do my physical exam, and that is how I arrive at my diagnosis. I have lots of other things that can help me arrive there, but that is the core. And so I always tell patients that when we're trying to search for uncertain answers, it's really a jigsaw puzzle. We have all of these individual pieces, and sometimes pieces are missing and sometimes pieces don't fit. But at the end of the day, you don't need every single piece to get a clear picture of the idea of what you're dealing with. And so that's really what we're doing. You walk into the room and we start assembling pieces. Do you want me to keep going with that?
No, that's excellent. And with his case in particular, there's some balance problems. He lives alone. He has a dog. This is what we deal with a lot with these falls that happen. And I don't know, Lisa, with this situation, social work, and is there resources that we could provide for him? And
of course, there's always help out there. It's important to ask the questions. Doctors can't always predict, or us professionals can't always predict what's going on. When I first meet a patient, I'll do a full assessment, not necessarily on your medical side of things, because that's the doctor's job, but I'll do a full assessment on who are your support system? Who do you call when you're having a good day? Who do you call when you're having a bad day? Are you a support group, social sort of person? Are you more introverted, like someone told me earlier, and prefer to be by yourself? Are you someone like Jimmy, who is really into exercise resources and wants to get out there and be physically fit in a really big way? Or are you someone that more prefers to do it at home, maybe watching YouTube videos? So there's lots of resources out there for every single person, regardless of how they like to interact with either their social world or their personal world. But it's just a big assessment on what makes you you, and what is quality of life to you, and what does that mean for you moving forward with Parkinson's disease. Yes, we can manage the symptoms, but like Jimmy said, we all carry burdens and we all have things that we need to live with, and how are you going to live with those and move forward?
I think it's important to realize that when you guys go to an appointment, if it's in person or video, that you always have somebody with you, right? So if you're there alone, I can't tell you how often it is that I have patients in my office alone and I haven't maybe seen them for 6 months or a year or even a couple of years, and I ask them how they are, and they're like, oh, I'm fine. Well, if you were fine, we wouldn't have actually called to schedule an appointment. And if the care partner was there, then the care partner, would be it the spouse or maybe a son or a daughter or a hired care partner, can actually provide a lot more information. So that kind of goes to Cheryl. Were you there when Jimmy got diagnosed, and have you been at all these appointments? And do you think it's important?
Yeah. So as he shared, no, I was not there when he got his diagnosis. In fact, he didn't tell me for a very long time that he had Parkinson's. And I think it was more out of guilt, or he knew I was going to suspect something was wrong because he was taking medication, that he finally disclosed to me that he had Parkinson's. So I think that's what's hard for a care partner, is trying to find that balance. But what I can tell you, we went through 8 years of, I call the dark years, where we did not do anything in terms of managing or treating Parkinson's disease. And I look back on it and like, why did we do that? When there's so much out there to help you. And it's finding the combination that works for your quality, like you said, the quality of life. What do you want your life to be? You have Parkinson's, you can't change that, but you can change the way you live your life with Parkinson's. And it's finding your I'm gonna call it tribe, because it's gonna be a combination of people, your medical team, your social team, your friends, your family. All of those will play into a part of what you want your life moving forward with Parkinson's. So as much as possible, I try to be there for Jimmy. I can't be there all the time. And it's gonna be hard, but it's that tribe that we've built through the years and these connections that it doesn't have to be just me too. It doesn't have to be just the care partner. When you build that tribe that you trust, there's somebody else that's always looking out for him when I can't be there.
Fair enough. I know that in all of our organizations, we try very hard to make sure that our patients not just see their medical team that's prescribing medications and treatment, but also seeing things like physical therapy. So, Sarah, when you see this person, what would you tell them? What would you do?
I think the nice thing about physical therapy that we get the advantage of over other people is I see people over and over again in a short amount of time. So I think that was a great point that Stephen had about building a relationship, and I love it when my patients refer to me as a part of their team, right? Because that's how I see it, right? And a lot of my first visit isn't a ton of physical assessment. It's a lot of questions, right? A lot of getting to know someone, getting to know them outside of a diagnosis, right? Do you like to golf? Is that your incentive? Do your kids play soccer, right? What is the thing that means the most to you? Because my goal of that session is to figure out how exercise works in that, right? I could sit here and talk to you about hundreds of articles that show exercise improve cognition, balance, walking, constipation, sleep, depression. I had a researcher recently tell me that it's hard to get funding for research for exercise in Parkinson's because the evidence is already too good, right? So I don't need to tell you those, but what I will tell you is people don't do it, right? So my goal of that session is to find the how to make people do it. I can give you a perfect exercise program later. My goal day one is to get you doing something.
So Sarah, you think patients should be referred right away?
I think the day they're diagnosed, they should be referred to physical therapy. Because I think, just like Jimmy said, like that if that diagnosis had come and then maybe he had a chance to talk to a physical therapist right away about how to improve it, a one-on-one personal connection, not a book, would those dark years have happened? I don't know.
The dark years, I know that was really tough, the 8 years. Linda, I mean, that's one of the underused things is, psychology and, neuropsychologists like yourself. What sort of things could maybe a neuropsychologist or a psychologist have for those dark years for patients initially sometimes?
Yeah, and I think it's good that we have this example where we're seeing cognitive issues aren't coming out in this interaction, and yet all of the movement neurologists know that it's important to screen for cognitive problems. And so that's a typical part of their baseline gathering and then monitoring things over time. So doing a screening of cognition as well as mood, like you're saying, those dark days. We know that depression and anxiety, we have high prevalence rates of those types of mood issues, even prior to the onset of the non-invisible symptoms, we'll say, those motor changes. So the invisible symptoms are there, and we want to always encourage good collaboration, discussion about that. I think a neuropsychologist may come in, or a psychologist may come in if you're really feeling stuck and needing some support to process those emotions and to problem solve about what can be done to improve the situation.
You bring up a point about cognition, and oftentimes we don't either have the time or the resources to make referrals to neuropsychology or do a full battery of cognitive testing. But right there in the clinic, there are very easy ways in which you can at least appreciate that there's a certain degree of cognitive impairment. And so some of you who may have seen me in my clinic, I often will ask the individual with Parkinson's for some information, how they've done over the last whatever time period. And oftentimes they will look to their partner to answer on their behalf, and the partner will gladly do so, enabling them. And so oftentimes you'll hear me say, no help from the audience, because I want to know how it is that they respond to me. How quickly is it that they process that information? How quickly is it that they understand what I'm telling them? And so that right away gives me a pretty good understanding as to whether we're dealing with some mild, moderate, or even more significant cognitive impairment. And if it is moderate to significant, I think it's well worth making a referral to a neuropsychologist or a psychologist, or doing any kind of cognitive testing for that matter.
And to the point you made earlier, we have care partners participate in the evaluation, come in and discuss, so that I get the person living with Parkinson's, their perspective, but also the other person giving me another perspective and insight. That's very helpful.
So Mark, you haven't said a word here. So I was just wondering if you felt that you could contribute to this now.
Yeah, I think so. So maybe taking it in two parts. One part is I am a PA, and working in the motor disorder clinic, my role is sometimes slightly different than what the MD's role is. So they're going to usually see you first. And as we bring more PAs to help with the load of patients that we have, get them in a timely fashion, because the waits, as you know, can be pretty long, as the movement disorder specialists are more rare in terms of the discipline. So the PAs can help by seeing what the MD has come up with in a plan and keeping to facilitate that plan. So we'll spend a lot of time, and I hear a great theme of everybody's trying to establish rapport when you first come in, and we would with this gentleman too, and a physician assistant like myself would also do that, so that we can work together, because if we don't have that rapport, we can give you great advice and adjust your medication schedules and things like that, and you're not as likely to take them. But if we get that rapport going, then that's really, I think, helpful. But a big part of my job is to see that a plan has been started, a medication adjustment has been started, and then to see how it's going when you come back in, and then adjust it further based on what the MD was thinking in terms of the long-term goals, and listening to see if you had side effects and all that nuance in terms of that. And as an acupuncturist, looking at this gentleman's case, I see that he has some anxiety, and he has some dream disturbed sleep and ending up on the floor. And acupuncture, which is a system of using little needles to stimulate the nervous system to balance out some of the neurotransmitters, as we call them. Studies have shown that it has been helpful for those parts of his symptoms. If he had pain, it would also be, I think, helpful for him too. The studies are supportive of that. So those are things that could be talked about. But one of the other things that acupuncturists also encourage are lifestyle recommendations. And I have a way of remembering them. I call this 7 seeds of security, or the 7 seeds of recovery. And S is the mnemonic, so S is for sleep, E is for exercise the body, so the physical therapy. The second E is for exercise the brain, and doing all the cognitive support kinds of things that we recommend and refer out to. D is for a diet. From the acupuncture point of view and the integrative medicine point of view, a lot of people suffer from a lot of chronic inflammation, and we don't think those are good for neurodegenerative type diseases. So I say a diet that's lean, green, and clean. So to keep it simple, modified Mediterranean diet is a great example of that, and there's good studies to support that. That's helpful. And the last S is to socialize, stress reduce, and reduce harmful substances like too much alcohol, cigarette smoking, for example, those kinds of things. So, yeah.
So, you know, we're talking about tackling tough cases, and so far this case seems pretty straightforward.
Yeah.
If we added a few things to this case that made it a little bit more tough, you know, I'm kind of wanting to hear from you guys, like sort of what we can do as a medical team to help support this individual. What if this gentleman had no family to fall back on? Wife maybe had passed away, or maybe he's divorced or separated from his wife. Kids have kind of flown coop. They now live on the East Coast somewhere. So and you know, they live maybe on a very large property that has a lot of ups and downs, and you know, we're just escaping fire season here. I mean, what wouldn't we do for this gentleman, knowing that he's got walking difficulties on this large property, no family support? You know, what kind of things can the medical establishments do to help support him?
So first, I just want to tie this back to the palliative care conversation that happened earlier. You actually are seeing a palliative care team right on this stage, and we don't all work for the same institution. So, you know, Kaiser may not have every single thing you need, but there are resources out there, and we're all well connected as a community, as all of you are. So we can help with more complex situations, because sometimes it's, I don't know the answer, but let me call Dr. Kandar and see what he has, or let me call Mark and see what he has to offer. Let me call, you know, whoever we know in the community. Sometimes it's community organizations like the Caregiver Resource Centers, which I think a couple are here today, to help people that maybe don't have the family support that they need. With him, it is about finding out what supports he does have, because he probably does have some supports, whether that's, you know, if he has a farm, he probably has a veterinarian that comes on and helps him with that. Maybe he has people that work for him, maybe not. So there's lots of things, and it's playing on what those pieces that he does have and seeing if we can maximize those to the best of our ability. The other thing for him would be to connect him to things like this, whether it's via Zoom, hi Zoom people, or whether it's in person, you know, whatever would work for him. So it's about asking the questions and seeing what happens, because good collaborations can happen when you least expect it.
Yeah, I would just tack on to that too, that support groups are so crucial for people, because we up here, as much knowledge as we collectively have, we don't have Parkinson's, right? So I can't model what the appropriate response is, but being involved in a support group where you can be open and see other people at different levels of the disease is hugely helpful for someone, especially when they're on their own, right? So to develop that tribe, right? And I know there are support groups here, there are Rocksteady groups here, where resources come more from that than from me, as many resources as I have. So I think that's just another thing for, you know, a more complicated case.
And I'm glad you brought up the thing about support groups. I think a lot of people, they're under this impression that support groups is like some sort of, you know, place where you sit in a circle and you commiserate about your Parkinson's disease or what could have been. And they do not need to be that way. They can certainly be a place where you feel welcomed, a place where you feel that the community knows you, understands you, and you don't have to feel judged. But also it's a place where you get educated on other things that might be available to you that you didn't otherwise know. So how many of you here in the audience actually go to a support group?
Oh, wow. That's a fair amount.
That's a lot.
Yeah.
And how many of you are support group facilitators?
Woo! All right.
They're the ones that deserve that.
Yeah.
So definitely the resources are there. If you guys have an opportunity, please do so if you haven't been to a support group. I know Pank has 36 or 39 support groups, so certainly there will be one in your community. So, Steve, I have a question for you. Would you start this guy on medication?
So, absolutely, right? And so for patients who come to you with a problem, it's our responsibility to try and figure out how do we identify the problem. And so rewinding just a little bit, oftentimes we think of Parkinson's disease as synonymous with tremor, but it's not necessarily the case. You can be diagnosed with Parkinson's disease and never experience tremor at all. And so a lot of patients come to me and say, I have a problem, but I don't know if this is Parkinson's or not. And it becomes very important to have these conversations because just like it takes an entire team of individuals to address individual problems that we find, there are a host of problems that you can be experiencing that you may not recognize as being an issue that has to do with the Parkinson's. But if it's brought up in clinic and we can address that issue, then suddenly we have routes to fix it. And the same thing goes for support groups, finding other individuals who have found unique solutions to problems that only you experience, or you find out that maybe you're not alone and other people are dealing with this too. So in this gentleman's case, it is obvious that he is coming to me asking for, I'm having this issue, how do I address it? And so specifically with regards to overall treatment goals, which has been a big part of the conversation today, that's the first part of the conversation. What do we do about addressing your problems? Because I want to make sure that my goal point is the same as your goal. And because sometimes that's not always the case. And so you have a very clear conversation. What is his ultimate goal? Does he want to remain on this property? Does he want to remain taking care of these things and living alone with his dog? If that's his ultimate goal, then we'll do our best to get him there. But it certainly changes the types of medications or treatments that we would offer based on risks and side effects. Does it increase your frequency of falls? Would the potential side effects of a medication create a potential dangerous situation that may not be something where if you had someone living with you or at least checking in, we would avoid in other circumstances?
Okay. We should probably maybe move on to the next one.
Move on to the next one.
So this is actually the exact same case, but we flipped the script a little bit, and it's a 38-year-old gentleman. So to remind you, it's a 38-year-old right-handed male that's a farmer, just like the previous patient, lives at home with his young family and dog, complains of a left-hand tremor with a little bit of balance issues and some slowness in his walking. That's been going on for 3 months. Had a fall, tripped over his dog, and landed on his right hand, leading to wrist pain. Again, same scenario as the last case. He reports a loss of sense of smell for years and falls out of bed when sleeping. So he saw his family doctor regarding his wrist and was referred to a neurologist to be evaluated. So exact same case, but we want to actually detail a little bit that, young onset Parkinson's versus typical onset Parkinson's, even though it's the same condition, there are different things that might plague a typical onset patient differently than maybe a young onset patient. So I'm going to put this first with you, Stephen, and then with you, Cheryl, afterwards. So how do you approach this? Do you approach it any differently than you did with the previous case?
So it all begins with that conversation of what are your goals, right? And so for our previous patient, it's possible that he says, I'm done. I've been taking care of this property for 30 years. I don't need it anymore. I'm ready to move on. And in which case, his needs are different. But for a young father, it's possible that he's expecting to work for the next 30 years. And so how do we tackle that issue? And if that's tied into the land that he's responsible for taking care of, then we have a different problem that presents itself. And so with that in mind, for this particular patient, the younger individual, we start talking about things like, what are we predicting for treatment 30 years, 40 years down the road that maybe is not such an issue with someone who is a little older at the onset of their diagnosis?
Would you choose different tests or medications compared to different age groups, or would it be the same approach?
So in my experience, just trying to decide whether or not diagnostic testing is needed, whether this is labs or imaging, this is definitely a two-way street. I always sit down with my patients and I say that I am not the captain of the ship, right? At best, I'm the first mate, but you are the captain of the ship, and it's my job to offer you the best professional advice that I can.
He's a married man, you can tell.
I might be second mate in the home, but so for that, with regards to how the diagnosis is reached, in some situations, I sit down and I do a physical exam and I listen to a story and I say, I have enough information here. I see the jigsaw puzzle. In my experience, I feel very comfortable making this diagnosis, but sometimes a patient says, it's not enough. For me, it's not enough. And that is justification for having a discussion. What does that look like? Lab tests, imaging studies that can help us further clarify the picture. And so for a 38-year-old who is unfamiliar with things like Parkinson's disease, I think that conversation generally spins differently. For me to sit down and approach a 38-year-old and tell him, I think that this is Parkinson's disease, generally you're looked at like you're crazy, because we don't typically think of Parkinson's disease as someone that can affect someone who's 38, but unfortunately it can. And so with that regards, that diagnosis part takes a little bit stronger emphasis, or at least a bigger part of that first visit. And then as far as treatment is concerned, once the diagnosis is established, it can affect, which direction that we decide to go. For someone who is expected to start his day and then for the next 12 hours, on his feet working with very little time to eat or drink, much less take medications every 2 hours, yeah, it'll absolutely change the medications that we suggest.
So Cheryl, kind of pitching it to you, when someone's young, and like Jimmy was 27 and he got diagnosed, did you guys seek out a second opinion? Did you ask for further tests? I mean, he mentioned that he had 2 DAT scans done.
Yeah, so I think, it was the whole disbelief. And like you said, that especially early onset, like you can't believe it. And the other piece is at that time, there were really no symptoms. There's no visible symptoms that we could tell. So if you told that when he first told me, it's like, you look fine, you're okay. And I think we were at the time very much believed that he'll be okay for a long time too, that we can hide this under the covers. And when I say the dark years, that was the very wrong thing to do. It's just to hide, because what that did is it added on to the stress of what I would say is everyday life for a young couple, career-minded people at the time. It added on so much stress that it actually, I feel like, looking back, it accelerated his onset of more symptoms. And because we were in so much denial, we didn't educate ourselves. And for me, we didn't talk about it, but the biggest symptom that was very difficult for me to come to terms with for Jimmy was apathy. And that, I think, was the biggest stress in the marriage, if I would say a relationship in the marriage, was because it changed his personality. This was not the Jimmy that I knew, that I grew up with, I met in high school. This is Jimmy, a very different Jimmy, and you start projecting, what is the rest of our marriage life going to be, and what is it going to be like for my kids, right? They're very young. Who's growing up with a father who has Parkinson's. And I think that was the hardest part of it. And I think when I look back, is this Jimmy that I know? Am I talking to Parkinson's? Or is the questions I was asking? And when I finally educated myself, I would say that's the biggest step, is I think that's what helped. It helped me understand what Parkinson's could be, looking into the future. And I think when he had his rock bottom moment of, falling down the stairs and changing his outlook of how we handled Parkinson's, then I felt like I was a care partner. Because now I'm part of the conversation with him in terms of, okay, how are we going to attack this? What are the things you want to do? Do you want to still work in corporate life, like little things like that, or do you want to be a stay-at-home dad? It's those conversations that I felt like at least now this was our marriage. Moving forward, we're going to tackle Parkinson's together.
We talk about Jimmy having these dark days, these dark years, 8 years, right? Which basically is a reflection of him not being honest with himself. How long did it take you to be honest with yourself about him?
I would say it's the same thing. I took a lot of cues from him in terms of Parkinson's, and what I would say for any care partner, you can't force them to deal with Parkinson's. Like, yes, you can say, you need to exercise, you need to take your medication, but it has to be a self-will to do something about it, and I can help reinforce. But I can't force them to exercise. If we can't force him to exercise, it has to come an acceptance from himself to want to deal with it. So I would say we're about the same time. And when he realized that moment, and I was all in, let's do this together and figure out, like, how can we move forward? And I would never have said, when we first got married in 2000, he'd be a reality TV star, or reality TV personality. We never would have projected that. But at the same time, Parkinson's brought us to that journey. So like we say, it's good and bad, but I think it's all in the mindset. It's in the mindset of how you attack it together.
So you brought up the word apathy. Maybe a lot of folks in the audience don't know what apathy is. Linda, do you mind actually educating us on what apathy is?
Yeah, because we do see where we get confused about depression versus apathy, right? And so when we think about depression, we could see a period, a good substantial time where people are having a loss of interest and pleasure in things that they once enjoyed. When you talk with people, usually they'll confide in you when they're neurologist or neuropsychologist that, yeah, I really miss the old me. I'm going through a grieving process and all the changes that I've had to adjust to. In apathy, what I tend to see is that the care partner is saying, he just sits on the couch, or she doesn't do anything with the family anymore. There's really an emotional indifference. They could really care less. And there's not really this angst of, I miss the old me, I miss the old us, what we had, the grieving. Rather, it's more of this frontal lobe, making that way down to the subcortical part of the brain, and those connections are not really communicating as well, and it's creating this cutoff from what the person has in terms of their spontaneity and interest in the world. So it's really just like a brick wall is in front of them.
Linda, is it safe to say sometimes it manifests as sort of a numbness, just for folks, they just feel numbed out. Sometimes that's what I hear folks say when I ask them, when I think they're apathetic, do you feel numb? Or that's what they give me back. They say, I just have this sort of numbness where I used to feel intensely about things or more sensitive to things. I just feel numb. Sometimes I think in that younger generation of a patient that's the word that they might use. Do you think that's safe to say?
Yeah, I'm really glad you brought that up, because it's important to have these kind of code words or these ways of describing what we're going through, these metaphors. So yeah, numbness.
Or content. I know a lot of patients will say they just feel content. That yes, they don't have the energy or the willingness or even the desire to go be social or to go to the, family Christmas party. They're perfectly happy sitting on the couch all day. Their loved ones usually are not happy with that, but they are. So they're kind of content and they're happy just sitting on the couch all day. But that is part of apathy, where they just don't have the desire and the energy and the willingness to maybe find joy in other places.
So how do we treat apathy? I mean, obviously Jimmy's not apathetic. I mean, American Ninja Warrior.
Well, he's not now.
It motivated me to get off my chair. I mean, that was amazing. Stephen, Sarah, everyone, chime in. It's a very difficult symptom that we deal with every day with our patients.
I would say I get a lot of this, right, in physical therapy, and it's interesting listening to kind of the more medical side of the diagnosis. For me, I always see it as the people who know what they need to do but don't do it, right?
Yep.
Right, and that's kind of what I see physically, and I think things that have been the best are peer modeling. So that's where kind of the group exercise class comes in, because when you can see someone else succeed, I have a lot of people go just like, hey, message Rocksteady and see if you can stand in the back and just watch a class, right? You don't have to go, you don't have to participate, which is absolutely true. Just watch other people succeed, right? And sometimes that will help break through. But I think it's kind of what we talked about earlier. What does matter? So if you're numb to life, what do you still care about? Is it you want to get on the floor with a grandchild? I have a patient right now that we're working up to hopscotch because she realized when she went to play with her granddaughter, she couldn't do hopscotch. And so that is her goal. So I think, finding anything you can what holds the most value, and let's center the goals around that.
So, Sarah, what happens a lot and what patients will tell me is that, actually it's the care partner that tells me that Well, he did really great at physical therapy. Sarah made him walk up and down the hall like, without the walker. But at home, he's using the walker, he can barely make it to the bathroom. So how do you keep that motivation and that going after the clinic visit, after your visit with PT?
Yeah. So, I think I can't emphasize enough the role of integrating into some sort of group exercise. Or, some people are not group exercisers, and I can respect that. Then we need a very strong routine.
But family exercise.
Yeah.
Even if, hey, do you want to go for a walk this evening? So that it's not about them and about them needing exercise, but let's just do this as a family bonding time, spending quality time together.
You know what Cheryl told me yesterday was they did Planksgiving like 2 years ago? Yeah, Planksgiving.
That's too funny.
So can you explain that a little bit? So
So Jimmy, if you follow him on any of his social media, he loves challenges. Or if you challenge him on anything, he will do it pretty much. But for the month of November, I think he came up with Planksgiving. So which is every day in November he did a variation of the plank. Every day, and one of them for Thanksgiving was, so he cooked our turkey, and then in a plank position on my kitchen counters, he carved the turkey for the rest of our guests. So,
Wow.
so I think that in terms of getting them to do it, you gotta put an element of fun into it, and I think that's key. And if it's fun, if it's enjoyable, even if it's so silly, it kind of breaks up the monotony of having to do it. I think there's this shift in mindset of I have to do it, or same thing, but I get to do it.
Yes.
So it's a big shift in mindset, and it's how to get them there is the hard part.
Right.
One of the things that I do too is I try to sense whether you're an extrovert or an introvert, and then that helps guide my recommendation to you. If you're an extrovert, I'm going to send you out to group classes. Go and take a dance class. Go and do a rock steady class. Go out to the gym where they have classes. If you're an introvert, I might still send you to the gym, but I'm going to have you work on those solo things that you can do by yourself and put in a Walkman or listen. I just dated myself. Sorry. Put in some music to listen.
iPod.
Yeah, iPod. Thank you. And then or listen to a podcast, something that you like. If it's like intellectual stimulation while you're walking on a treadmill, or even better, I'd like you to get you outside to get that sense of awe from nature, if you like that kind of thing, or if you have a dog that you can walk that's not going to pull you over, and it's something you can do alone, that might be realistic for you depending on what your preference style is. And we know people are different that way. But I also will ask you, after you do the exercise or whatever it is that you need to do, how do you feel? And try to remind you that that's the reward of doing it. And you don't get to feel that unless you do it. So we try to do some motivational coaching in there, and almost use like ACT type cognitive therapy, which says if you act this way, you feel worse. If you act that way, you feel better. Which way you want to be, So sometimes we'll just use some realistic recommendations like that, and we can get you hooked up with a counselor if you need that to help get you there too. Those are some of the things that we have the ability to make referrals for.
I think on that note, we're kind of hitting our time, so we're going to try to motivate all you guys because we're going to actually have a little dance breakout session. Perfect. So we'll reconvene this panel in about 10-15 minutes. Okay. Thank you, everyone.
Yes, thank you.
Thank you.
So I'd like to invite Dr. Divya Kaul and also Krupa Trivedi. So these are both colleagues of mine in Kaiser Permanente, and they're going to be taking us on a movement break. So a little bit about both of them. Dr. Kaul is a movement disorder trained specialist. She actually works out of Walnut Creek Kaiser. She did her fellowship training out of Stanford, but what's unique to Dr. Kaul is she's probably one of the only Dance for Parkinson's certified movement disorder neurologists in the country. And she's working with us
in the Kaiser network, and with her colleague Krupa, who actually did her doctorate in physical therapy, and yes, I did say doctorate, out of NYU, joined her when then they got together in 2019 and started a Dance for Parkinson's class out of Kaiser in Walnut Creek. So they're gonna kind of take us on a little bit of a whirlwind tour with a little bit of Bollywood flair, I think. So enjoy.
Great. Well, hello, everyone. All right, so we're going to do 3 songs, just a little bit of everything. The middle portion will be, I'm classically trained in Indian dance and so in Bollywood, as Dr. Kandar mentioned. So is actually Krupa. So we're going to have a little bit of dance. I want to just let you know this is about having fun. This is about having a good time. And this is about doing what you're most comfortable with your body. If you feel like the movements are too much, no worries, you can make up your own movements, that's perfectly fine. We're just here to have a little bit of fun. And if you feel more comfortable doing the dance in a seated position, that's all perfectly fine too. All right, let's have some fun. Just moving our hands. Point upward. 'Cause you're a sky full of stars. I'm gonna give you my heart. 'Cause you're a sky full of stars. 'Cause you light up the path. I don't care if you wanna tear me apart. Stars. And point. You're pointing to all those stars in the sky. Georgia, get more volume.
Cause you're a sky full of stars.
And back around.
Give you my heart.
Again. And back around. And this time you're going to point to a neighbor, say hi to someone. Make eye contact. Smile with your eyes, with your mouth, with your body. And we're going to point again to the sky. Woohoo! Give yourselves a round of applause. Woohoo! All right. We need a little bit more volume, I think, for the next song. The next song is a Bollywood dance song. We're going to be using our shoulder. We're going to use every body part. And do not be shy in moving those hips, because you're going to be moving them soon. Next song. So we're going to start with the right shoulder. Up. And then left shoulder. And alternate. And hand. And we're going to stand up. And both hands on the hips. Both hands. Side to side. One hand. Both hands. Side to side. Hands up. Side to side. And balance. Double time. Side to side. And buttons. Woo! Perfect. This last song is a really special song. I hope you enjoy it. It's about having gratitude, and please join me in dancing to this next song, which you will all recognize.
I see trees of green, red roses too. I see them bloom for me and you, and I think to myself, what a wonderful world. I see skies of blue and clouds of white, the bright blessed day, the dark sacred night. And I think to myself, what a wonderful world.
Give yourself a big hug here.
The colors of the rainbow, so pretty in the sky, are also on the faces of people going by. I see friends shaking hands, saying, how do you do? They're really saying, I love you. I hear babies cry. I watch them grow. They'll learn much more than I never knew. And I think to myself, what a wonderful world. Yes, I think to myself, what a wonderful world.
Give yourself a big hug. You guys did so well. Enjoy, 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 and remember to keep having fun.
Thank you so much, Krupa and Dr. Call. So hopefully you guys are a little bit more awake, got the juices flowing. This is going to be the last part and segment of our conference today. And it's one that many people really appreciate because it's really your questions being answered. So years ago, we thought instead of having a podium and a mic right here for you all to come up to, it might be better for you to all submit your questions in advance, and we'll use the same panel that we had before to be able to help answer them. I apologize in advance if we can't get to your questions. There were actually quite a few hundred questions that were submitted. We did whittle down a few questions simply because if it wasn't the right appropriate question or the right venue for it, we did discard it. But many of the questions were, interesting enough, similar questions that a lot of you actually had, and we're going to try to go and run through as many of them as quickly as possible. So my only request of the panel is that we're going to try to make these short and sweet, but really very informative, kind of rapid fire answers for our audience.
Go ahead.
Okay. So this was a good question. It came up this morning. What are internal tremors? So I don't know if Stephen, if you're able to help define that, or because Jimmy had mentioned that this morning.
Yeah, so we already talked about how, there's a huge variety of symptoms that you can experience as a component of your Parkinson's disease. And so internal tremors are very well described, very relatively common symptom that patients report where there's no visible sign of tremor, but it's still there. And we are approaching the point where technology is helping us to suss these things out. We're using devices installed in your cell phone, accelerometers, to try and measure those types of things to figure out, is there a tremor there that exists that we just can't see with our eye, or is there a tremor there that we can feel but not see? And so be encouraged that this is something that other people experience, and we've had success in treating it with medications.
Yeah, can I just add to that?
Yeah, go for it.
So the internal tremor, and this is one of the things I encourage with Jimmy, is you need to tell me what you're feeling. So his internal tremor is actually in his ear. So he hears a fluttering sound internally. So sometimes when I'm speaking to him, I think it's his right side, he can't hear me, and it's because of this fluttering sound. So by him making that aware to me, I know when he's not hearing me. He's not ignoring me, it's just he's hearing the more predominant fluttering sound.
Some of the things that happen when somebody brings up internal tremor in the office, if it's with their primary care physician or maybe a general neurologist that's not well versed in the movement disorder space, they kind of dismiss the symptom because they can't see the symptom. Well, not everything in Parkinson's is something that you can visibly see. And if you're having external skeletal muscle tremor, who's to say that you can't have internal smooth muscle tremor as well? So I kind of feel like inside things might be moving. It doesn't matter where it is. It's just something that, in my mind, if somebody expresses, or at least it has the ability to express that they are having internal tremors, I feel like it's probably a lot more common than we ever give it credit for. So this question came up, it's more for you, Sarah. What amount of exercise is recommended daily for individuals with Parkinson's?
So there's a lot of various research paradigms about how much exercise. So I would say the first thing, if we're talking about, two different questions. What's the smallest amount that can benefit you, right? So the smallest amount is any more than you do right now, but your goal is to get your chunks of exercise into at least 10-minute sessions and to get at least 150 minutes a week. Now, you can do that any mixed match of ways. Now, is doing more than that better? Absolutely. A lot of places recommend 300 minutes a week. But this is kind of what we talked about, goal setting. You have to have achievable milestones and things to work to. So if you think there's no way I can do 300 minutes of exercise, well then again, that's not going to be helpful for you. So just focus on getting 10 minutes in a row and build up that time and have it be meaningful.
So is it okay for you to break up those sessions, 40 minutes, into 2 20-minute sessions?
Absolutely. Okay. So the 10-minute mark, what you're trying to build the 10-minute section is because that's where you start to get that cardiovascular benefit. And we didn't talk about it a ton this year, but I'm sure a lot of you know that when we do higher intensity cardiovascular exercise, we release certain protective factors in the brain that slow progression of Parkinson's. So once we can get to that barrier where you're doing at least 10 minutes in a row, we start tapping that.
The other thing I would add to that too is if you can time it with when you're in your on position with your levodopa, if you're using levodopa, I think it's going to be easier for you and you're going to be more successful and less fatigued. So I think I would add that piece to it too.
All right. So go ahead.
Another question on exercise. I have a pre-PD back scoliosis and lower back ruptured disc. The Parkinson's exacerbates this pain. How do I get past this pain? I'm already taking pain relief classes. Is there any hope? I mean, Sarah, Mark, these are all good questions for you guys.
So this is a place where acupuncture would come in. Acupuncture has been well studied for low back pain. Herniated discs are part of that, and osteoarthritis and spinal stenosis, that kind of thing. So often patients, and this person said that they were taking pain medications, and sometimes those can be the muscle relaxers and the narcotics, and those add and compound to constipation, which is another problem. So trying to use alternative methods is going to be a good idea here. So having acupuncture, to give you an example, 2 times a week for 3 to 6 weeks could give you some pain relief in that kind of a scenario. I mean, each case is individuals, but at least there's some, research that backs up that can be helpful, and it can keep that pain away for quite a long time, according to the studies. And then you can also couple that with your physical therapy and your home exercise regime to help with those kinds of symptoms.
Yeah, so I think kind of adding to that, along the lines of acupuncture for pain relief, TENS can be helpful, TENS unit, which are pretty commercially available now, yes. But I think, unless you have DBS, I should put that caveat to the doctors. So I think an important thing to think is if that back pain is limiting you from doing something like walking or biking, what about pool exercise? What about, a mat Pilates program? There's so many ways we can get around that, addressing your core strength at the same time we're getting that aerobic component. Exercise is not one size fits all. So seeing a one-on-one physical therapist, having them look at you and go through exercises together to figure out what can we do where we're not increasing your pain, is absolutely paramount to being able to achieve all these things that we talked about that are beneficial without increasing your pain.
Well, and I think the dance was a good example of that, where you saw they were dancing in your seats. Some of you were standing, some people sitting. You can still do exercises, just modify it for yourself, that if something is hurting, just maybe do less big motions or smaller motions, or just know your limits and do it for 2 minutes instead of the 10 minutes and build yourself up to the 10 minutes.
I also have my patients use those pedal sizers, because sometimes they can do that, and then I have them put it up on the table too, and they can actually do the upper body that way. And when you get that heart beating and you have back pain, for example, or pain in other places that has less good circulation, like the spine, it's not quite as good as other areas where there's muscles and things like that. Getting that heart to beat harder, because you're doing that without stressing your body, because you don't have any weight when you're using a pedal sizer kind of things, and you can get those online pretty easily. That can be another way to do it too.
So Sarah, you had brought up deep brain stimulation, and there was a question in here. What does a panel look at to qualify somebody for, or make someone eligible for DBS? That's going to be for you, Stephen.
Yeah,
Maybe
and
a little bit Linda.
A big part of the conversation has to do with what symptoms you're experiencing and what is the best way to tackle those. And so with regards to DBS, the convention always says that with the exception of tremor, if your symptom responds to carbidopa-levodopa, then we ought to see improvement with DBS. And so that's where the conversation starts, but that's not where it ends. We've kind of talked already about how your individual symptoms are yours, and it doesn't necessarily mirror anyone else's who has ever experienced Parkinson's disease. And in the same breath, I can't tell you how bothersome some of your symptoms are and how difficult they are to manage for you with other treatments like medications or physical therapy or acupuncture. And so trying to figure out the best way to address those symptoms is part of the conversation of figuring out whether or not DBS is a good solution for you. And so to be clear, there are very few hard lines in the sand that we draw saying you are or you are not a candidate for DBS, but there's a huge amount of subjectivity to that where we have a conversation.
Right, but we tend to consider patients that are probably under the age of 80, people who respond to medications favorably, probably have motor fluctuations to where they get a good response, but then it wears off, and then they have to keep taking the medications frequently during the day, or those tremor patients that are not just responsive at all. And then coupled with that, we want to make sure structurally in the brain, there's actually viable tissue to be able to put that implant into, so an MRI of the brain, and then also a full battery of neurocognitive testing. You gather all that data together, and then you really want a multidisciplinary type approach to be able to decide collectively whether you are or are not a good candidate. So what would that neuropsychological and neurocognitive evaluation entail?
Right, so it's pretty comprehensive. Usually we meet with you and your care partner for about an hour or so just to get to know you, hear how you're doing, if you feel like you're doing about the same as your same age peers, or if you're noticing any difficulties day to day with your attention, memory, problem solving, thinking skills, what we call cognitive functioning, as well as day-to-day functioning and mood and interpersonal functioning. And then we sit down and we do the fun part, which is very sarcastic of me to say, but it's basically paper and pencil tasks that are standardized measures of cognition. So the neuropsychologist works with you to kind of take your brain for a test drive and see how you're doing. Are you scoring pretty much the same as your same age peers? Have you always had strengths in certain areas? And it's important to look at the person in front of us to be really sensitive about, strengths and weaknesses that you might have had for years. So from that's just one more piece of data that you use to work collaboratively with your neurologist and surgeon to make decisions about what types of treatment options are on the table for me, or what would be helpful to set things up for success versus failure.
Fair enough.
So that's good. As far as, since we have you on the, with cognitive issues, a lot of times hallucinations go with cognitive issues. And so this is a question, hallucinations, eating before bed seems to help my hallucinations. Do you have any other suggestions besides taking medications to deal with hallucinations?
There has been some research that says if we can kind of simplify our environment, especially with respect to glare. So if there's a lot of mirrors or bright lights or windows open, we can see where people will notice that glare can really participate, kind of start the show of having a hallucination. Also, sometimes if we have very dim light, though, it can create some shadows and difficulty with our eyes and that part of the brain that makes sense of our visual understanding. So those are two that I could think of.
Any other ideas, Stephen?
So I've had success with patients who, it's almost akin to exposure therapy, right? And so it's more about familiarizing yourself with the space and knowing that there is this lamp in the room that always casts this particular shadow. And so I recognize that for what it is. If I interpret it as a visual hallucination or a hallucination, it flips that insight where even though it doesn't necessarily change the phenomena from happening, it changes your internal representation of it and what your experience is like. So if you know that this is the place that occurs, you either can wrap your head around it and you correct the visual hallucination, or you change the position of the lamp and you try and prevent it from happening altogether.
Yeah, and tell me what you think about this, but I will say a lot of times I think that when people get anxious about hallucinations, they start to happen more. And so I've had some success with just recommend people see a psychologist or a counselor to talk about this and talk about what should happen when they wake up in the middle of the night and they're having a hallucination and their spouse is there. How can they manage that as a couple? And it seems like after they see these counselors, the hallucination rate goes down. I don't know if that's anecdotal, or what do you think?
Yeah, I think just having a plan of action, a plan A and plan B and C, and the more awareness we can have, it is very empowering just to talk about it, discuss plans, what could be helpful. Yeah, be prepared.
Lisa, have you ever come across a situation where, someone's having hallucinations and then the partner, the spouse, doesn't necessarily know how to respond to that, right? Do they tell them, no, that's a hallucination, this is not real, and really force that issue, or do they actually accept it for what it is?
Well, one, it can be very scary if especially the first time that you experience this with your PD person. So it's normal to be scared or to not know what to do. Any of us would be in the same position, even though we're educated necessarily in this area. But you have to look at safety. If the hallucination is something where it's like benign or they're safe, sometimes just being like, oh, okay, well, let me go check the kitchen to see who's out there, and I'll move them along. Or let me go, whatever, take the dog out, or if they're hallucinating about seeing a dog. If it's a safety issue, like they're trying to run out of the house or wander or some of those things, you might need to get your support system involved, whether that's neighbors or kids or other people in your home. Obviously, you can't join them in that, but you need to just reassure them. What I tell people is just say, I'm going to keep you safe. I know this is really scary for you. It's scary for me too. We'll figure this out together. And we're going to keep you safe in doing this. And just try to remain calm. If it does become too difficult to manage, it's okay to call 911 and to get other professionals on the scene to make sure that you are both safe in that situation if there's two of you in the house.
One of the other things that I sometimes do with patients too, and I teach many of my patients this, is a bottoms-up approach. And that is just to do a very simple thing, which is to shift your attention to your breathing. So often if they're having a hallucination or if they're anxious, those kinds of things, you can notice the breath rate is quite a bit quicker. So one fast way to flip the switches in the brain to calm down and stop that fight or flight response and do the rest and digest response, as I like to call it, is to just lengthen the exhalation. So you might help, if you're the care partner, demonstrate it, or you can use an app on the phone that actually has that kind of thing, and have them inhale for 4 counts and exhale for 8 counts, or just figure out what their breath capacity is, and then just do a 1-to-2 type ratio. And that can really settle them down right there on the spot within minutes to seconds sometimes, because you've redirected the attention away from the hallucination and something else inside the body, which is far away. So that's one kind of thing that you could do.
Another trick for your bag.
Yeah, exactly, tool.
Can I just add to that?
Yeah.
So one, I'm just fascinated that everyone talked about dog, because the few times that Jimmy has had the hallucination is he will say that our dog Max is like, did you take Max out? And we haven't had Max for years, more than a decade. And so I do try to keep calm. It's like, why are you talking about a dog we haven't had for years? But the other thing I do take note of is what are the circumstances happening before and kind of like what happened, because these are the mental notes that I would take and make sure he knows we need to talk to your doctor about this, because this is one of those symptoms that is it going to recur? But it's take note of that. It's like what was happening in that situation. I know that he did his long, I think that one was like, he did his really long run for training for a marathon. So I know he's exhausted. And when that is happening, that's when I know that a hallucination can come out. So it's a cue for me. I'm like, you need to rest at this point, because there's these other side effects or symptoms that are coming on now. So to me, I use that as notes for the future to make sure that we're prepared for other situations.
You know, all these questions that you guys helped us submit, even if we get around them or don't get around to them, they're actually good topics that are then written about in the Parkinson Association Northern California quarterly newsletter. So hopefully you guys, if you're here today, you're already going to be on the email list, or you're going to be getting mail delivery of these quarterly newsletters. Each quarterly newsletter, the feature article is written by one of the 4 medical institutions up here. So UC Davis, Kaiser, Sutter, and Mercy. And just this past year, we had a topic on Parkinson's disease and psychosis, really outlining what are hallucinations and some of the steps that can be taken to help mitigate that. And then at the end of last year, there was a topic on stem cell. You guys had a few questions here on stem cells, which we probably don't have enough time to go into, but it's 2 pages of information dissecting stem cells, what they are, and really what the future has in hope for use of stem cells in the future. So if you guys get a chance, go to the website, panktoday.org. You go to the Parkinson Path tab, and up will populate a repository of 6 or 7 years worth of all of these newsletters with feature articles written by movement specialists and other disciplines, experts basically, on each and every one of these topics. So it's really a nice library of a lot of information.
Okay. So moving on to other non-motor symptoms, there's a question here. How much water should I consume? Does increasing fiber help with constipation? What could suggest adding to your diet to consume daily without added medications? So I think, Mark, you had some insight on that.
Yeah, so one simple way is to figure out water is to basically divide your weight in half and then have that much water. It's not a great way to explain it, but let's say you're 150 pounds, you basically want to have 75 ounces of water, or you can have less if you have bladder issues and things like that. If you can get 4 to 6 cups in, that would be great. You don't have to have the standard 8 cups. And if you have trouble getting water in, those flavored water things that they have now that don't have any calories are a great way to do it, or to use tea, things like that. Are ways to get the fluid in, and that's definitely going to help constipation. That's one of the things you need to do. You need to float the boat downstream, so to speak. Another thing that's very helpful and natural, and that can help with dystonias and muscle spasms and things, can be magnesium, at least for the muscle spasms, but it also is a natural stool softener. Can help with anxiety and insomnia at the same time. So using magnesium as part of your bowel care regime can be a good idea. And then if you can get 20 to 30 grams of fiber in, it takes a lot really to go, and people are way under in this country. We average around 10 or 12 grams of fiber with our standard American diet. So you want to increase that, and one of the ways I have people do that is I have them make an oatmeal cookie with ground flaxseed meal instead of wheat flour. And then I have them put a sugar alcohol like erythritol or sorbitol as the sweetener, because it doesn't cause diabetes, and it sounds terrible as a sugar alcohol, but it's really benign, and it's a natural replacement for sugar. And that will really help you go, because you get probably 5 or 6 grams of fiber with one of those cookies. So if you eat 2 or 3 of those, that would be a nice way to get in some fiber that won't hurt you. So that's one of the things that I have people do. Otherwise, we do start to use the medicines, to help with constipation from Senecot in Miralax and those kinds of things. But I always have people try to do it with diet and simple kinds of things. Exercise also moves the bowels and things like that as well. And I'm going to even go out on a limb here and say, from the natural medicine point of view, probiotic may be helpful too, to regulate the bowel, and you want about 15 billion units if you pick a probiotic to do that, to help with dysbiosis in the bowel, because that's a problem with chronic constipation. Yeah.
You know, Mark, now that we're on the topic of different types of supplements and dietary changes and good choices when we actually have a menu in front of us, between you and Stephen, what would you recommend is the bare minimum supplement that somebody can take when they have Parkinson's disease? Are there vitamin recommendations, mineral recommendations that you guys like to give to your patients?
Yeah, sure, and you can jump in anytime with this. You want to start with it?
No, you go.
Okay. So a lot of times what Dr. Bird and I do, and she's my supervising physician in our Roseville clinic at Sutter, is we check everybody for D3, vitamin D3, because it may be involved in normal cognition. There's some studies that help to back that up. So we'll look for that to see if that's deficient. Of course, it's great for your bones. It's good for many other functions in the nervous system as well. And so we'll check levels for that. So usually 1 to 2,000 international units of D3 is recommended, and B12 in case you have neuropathy in your feet, which can come alongside the Parkinson's, and also to help with normal nerve function and cognition too, because we know there's some dementias that come from low B12, for example, and loss of sensation in the lower extremities. So we'll have folks take 500 to 1,000 micrograms of B12. I usually encourage people to take a multivitamin. I like the ones with the phytomultivitamins, which means they have the plant extracts in them and the fruit extracts in them, because sometimes we don't eat enough of a varied diet. Of course, I'm going to encourage modified Mediterranean diet where you're getting lots of fruits and vegetables, but if you can't do that, a little insurance is to take a phyto-based multivitamin. And those are some basic ones. I'm big on the probiotics because of the constipation. And then a lot of folks in this country are magnesium deficient. So that's kind of my base that I would use to help with supporting the neurologic system in general.
The only one that I would add to that list is CoQ10, which is helpful for some patients, especially with cognition. But the only thing that I would tag on in addition to that is that supplements are fantastic, but only if your diet is sufficient, right? And so my first preference would be that you eat a varied diet with plenty of leafy green vegetables, and that we avoid all of these things altogether, because to be frank, you're paying for the groceries already, why pay for supplements on top of it?
Right.
And so if you can find a varied diet, something, and you know, the word diet these days I find is very charged, because when patients say that, they think it's temporary, right? If I can change the way they eat for a little bit, then it addresses a problem. But really what we're talking about is lifestyle modification. You need to find something that you find delicious that is also good for your body.
So, you know, if you read Jimmy's bio, he likes to label himself as a semi-wannabe foodie. And so I want to know from you, Cheryl, did you guys change your diet? And you know, if he's changing his diet to meet the needs from the Parkinson's standpoint, did you and the kids also have to change your diet? Did you guys use a nutritionist to help you?
We did not use a nutritionist, no. I would say for the kids, it's been really hard to change their diets. We have the pickiest eater for my daughter. My son's getting better, but I would say the conscious one that at least he and I made was to eat more whole foods, less processed. It's hard to stick to a diet. Like you said, it has to be a lifestyle change, and what we felt we could take on and do it every day was to eat whole foods, or
that's great.
Just it was the easiest way. So get rid of processed as much as possible, and eat whole foods, fresh fruits, vegetables. That was the easiest way to do it, and I feel a whole lot better.
Yeah, if you think of it this way too, if it comes in a can, a box, or a bag, it's probably processed.
Yeah.
You know, and so trying to get things that you actually have to process yourself a little bit is going to be better, even though it's more work, but something that engages the mind and the creativity to cook and things like that. So that could be good for this. Yeah.
And the key is to start small. So it doesn't mean you need to go home tonight and throw everything out in your fridge and replace it with, you know, fresh fruits and veggies. Although if you want to do that, do that. But start small. Start like, okay, I really like spinach. I'm going to start doing spinach in my salads, and we'll have a salad every night for dinner. And just start that for a few weeks, make that a habit, and then you can start to incorporate other things. So as with exercise, everything, start small, because otherwise, as Sarah said earlier, you'll get really overwhelmed and probably won't be able to make it a permanent lifestyle change. But that's really what you're trying to do, is make these permanent changes that will just be part of life in the future, so that you won't even have to think about it.
I would probably say that if you guys have something in your pantry that has a shelf life older than you probably shouldn't eat it. And if you want to change your dietary pattern, go to the store, go to the farmer's market, be participant in creating the menus that your family is going to eat with you. So we take our kids at least to the farmer's market locally. We live in Northern California. We are not at a loss of farmer's markets. Yeah. And so walk through the aisles and see all the fresh fruits and fresh vegetables and color. And anything that's pretty deep in color is probably going to be good for you.
Yeah.
So those are the things you want to start adding and kind of dosing back into your diet, and staying away from things that are actually quite greasy, or again, having that long shelf life.
My office is embedded in a physical therapy suite, so I always think about rehabilitation as well. And occupational therapists are great to connect with. They have different suggestions for tool use. If you want to be part of cooking for your family, I really encourage you to set up an appointment with an occupational therapist, get a referral, because it can be very empowering. And also for care partners, it takes the weight off of your shoulders of doing one more thing, right? Hitting and maximizing those times when you have a bit more energy, because fatigue is a big issue here too. So think kind of wisely. Maybe we prep the salad at 10 a.m., but that's when my energy was the highest. So just more involvement is what we all encourage as well, kind of a partnership with care partners.
So there's another question. We're going to kind of shift gears here on how do you know you've crossed the line between compulsion and determination? And this is going to be for you, Cheryl, because a lot of folks with Parkinson's, if they're on certain medications, right, they might be at risk of developing an impulse control disorder, to where they are having compulsive type behaviors, where they might be excessively gambling or excessively spending or excessively eating. Well, some might argue that Jimmy excessively exercises. Can compulsion be a bad thing and a good thing? And how do you mitigate that as the care partner?
Yeah.
Pretend like he's not looking at you.
I know. No,
Was Jimmy here? Am I making
he's
him?
back, yeah.
Sorry, Jimmy.
There he is.
From a compulsion, I think for the exercise, so there is good and bad, and there has been bad, I would say, from a compulsion piece in terms of doing more. So when he started running, like I said, he accelerated. It was like, I'll do 1 mile, and then it's 5K, and it's 10K, half marathon, all the way to marathon. That was just from April to October, so that was fast. If you've gone through any sort of running training regimen, sometimes it could take years to build up to that. And so to me, it was actually a compulsion that I could live with. So for me, as a care partner, well, if he wants to do running, who's that gonna hurt? Like, that's something that he can do, and it's something that he loved. Had it been golf, it would have been the same thing. Before running, it was actually golf. I was a golf widow. He was always out playing golf, but now it was running, and he liked the medals, and it was a way for him, to meet those milestones. So I think if it's a healthy compulsion, it's fine, and that's from me as a care partner. I felt safe with that decision. Now, if it's something that's negatively affecting our family, if it was gambling and our finances are in trouble, or it's something that's endangering the kids, then I think that's when you intervene, or you pull in different help to say, like, this has to stop. But that's where you kind of create those gates, and that's one of the things. In some cases, I have pulled him back and said, "No, you can't do that." So it's a balance, but there's certain compulsions that I could live with.
That's the key, is that it's about finding the balance, but it's about how it's impacting one's life, or one's relationships, or one's ability to do their job or take care of their kids. So if it's so impactful, like the person is doing it so much that they're neglecting their other needs or other responsibilities, then it's an issue that you need to talk with them about, incorporate your team, engage your PD professionals, and talk to them about it. But it is about a balance, and just like hallucinations, some you can some are fun, and you're just like, yeah, all right, we're going to the moon. What are we doing today? And you just kind of talk about it. And other ones are a little bit more traumatic and difficult to cope with, and that's when you engage your team or your bag of skills that hopefully you're going to have when you leave here today.
So we only have actually a couple minutes left, and I really wanted to give everybody in the panel an opportunity to kind of give one pearl, something that you all can take home with you and marinate on, and hopefully it actually is impactful to your own healthcare and your own life. So I'll start with you, Nick.
Well, the one pearl that I see is, as we know, Jimmy came here today and he found his motivation. And so the key is to find something that drives you every day to something you love that you're going to do. And I think, can it be dancing? Can it be kickboxing, Rocksteady, Nintendo Wii? I mean, something that drives you to have physical activity, because we know that helps Parkinson's. We've all enforced how activity helps everything. Apathy is like one of the main things that we all deal with, and something that gets you physical. And all of us, I mean, as physicians, as social workers, as physical therapists, we all need some sort of thing to deal with our stresses. And I think you got to find something that you'll do on a daily basis.
I guess my pearl would be that take ownership, right? It's not about allowing your providers, your doctor, your physical therapist, your counselor, whomever, it's not letting them steer on your behalf and just sitting back and being sort of that unparticipant passenger. Participatory medicine is where you, as an active recipient of that medicine, take full ownership for what it is that you have. This is your body, this is your condition. So therefore, there has to be some degree of ownership on your part. If you're not happy with the healthcare that you're getting, then speak up, have a voice. If you think that you deserve more for what it is that you're getting, speak up, have a voice. If you need to go out and learn a little bit more about Parkinson's, well, you guys are already beginning to do that by just simply being here. Be engaged, take ownership, and move forward with this thing.
My pearl would be about self-compassion. And I think that could mean a lot of different things for different people, but just allowing yourself some time to process the emotions of the changes. Anytime there's loss or change in life, we grieve, and that's actually a healthy, normal human response. That's not major depression. So giving yourself some self-compassion, maybe asking yourself, how would I treat a friend? Now, how would I treat myself? What types of mindset or self-messages am I giving myself? Am I my own best cheerleader, or am I putting negative thoughts of defeat in my way? So just doing practices, whether it's setting some boundaries for a care partner to have a little bit time alone, to do some mindfulness meditation in a different room, or to do a hobby that they enjoy. And the same with the person living with Parkinson's, taking that time to set boundaries of, I got this, I don't need help, or this is much help that I'd like, or this is the way I'd like you to help, using your communication skills. I think it all kind of boils down to self-compassion.
I would say my biggest pearl would be just write it down. So I know that sounds weird in a technological age and nobody has a pen and a paper anymore, but what I found is so helpful is if you have a barrier, say you can't exercise or be active, and if you just take a pen and paper and say, what are the things that are stopping me? And write it down, right? And then you can tackle those things one at a time. And that's not just true of physical, right? But emotional things too. How are you feeling? Write it down, process it. I think that's been just one of the more helpful tools I've had people employ when I feel like I'm not getting anywhere. What are the limitations? Let's list it out.
So my pearl would be, we had a conversation about apathy earlier on today, and this is what was rolling in my mind that I didn't say. I've been practicing medicine for a relatively short time compared to other people here, but I had a mentor at one point who said, you can't help won't. And I feel like at this point I've learned that I don't think it was correct. Like, maybe I can't, but you can. And being able to flip that script and being able to recognize that, no, I am unhappy with this thing. I am unsettled at this point in life, or I'm frustrated with this issue. You know, that starts with you. We are here to help that, but it starts with you.
Mine is basically the same as look around this room and see if you are struggling, challenged with something, feeling like you can't do it anymore, feeling stressed out, feeling like, you know, my loved one's progressing and I just physically can't do it or emotionally can't do it. Look around. There's so much help out there. There's always someone that can help support you. Can they fix the problem for you? Maybe not, but sometimes it's nice just to know and be validated that it is that hard. And if you are struggling and having challenges, we all do in life, as Jimmy shared with us, we all carry burdens. Look around your room, whether it's someone that's sitting directly at your same table or whether it's someone on the outskirts, community programs, health institutions. Pick up the phone, ask the question. You will find people that want to help you.
I really appreciate what the panel has said so far, and I agree with those recommendations. I think it's very wise counsel. What I would add to that, and this may seem very difficult to do, but I would ask you to, every day or every evening, do a little gratefulness journal. Even though there's been a lot of loss, both with the person who has Parkinson's and the folks that are taking care of them, there's still some things that are good. And it's an attention-shifting practice because it's so natural for us to focus on what's not right and maybe how to fix what's not right. But I would encourage you to focus on what is going well for you. And as you start to do that every day, your mind will learn to find things that are going well and good that you didn't notice before. And it can improve the quality of your life through your perception. You're going to change the filter if you do it. And if you can get 3 good things to write about in the day, and when I do my journal, I write a little headline like, wife smiled and gave me tea this morning, you know? And then I'll write a little paragraph about that and what was involved in that, so I know why it was good. You have to write down why it was good. And then your brain will learn a new habit, and that can be really helpful when you're facing really difficult circumstances to help raise the boat. So, okay? Yeah.
All right, Cheryl, take it away.
Wow.
Bring us home.
Last one. So I guess my pearl I would share and my journey as a care partner is keep finding new ways to connect with more people, with more communities. Seek out those connections. I know the pandemic has been hard, but I think we can do it. What we've shown through this last year is you can still do it. Use technology or just reach out now that we can be more in person. Keep making those connections. I can tell you from the dark years where we were very closeted and we didn't talk about it, it was very hard. And once we came out, I'm gonna call it coming out, and we made connections and shared their stories, from a soul perspective, it has really changed the way we live with Parkinson's on a day-to-day basis. So those connections are key, not just physically, but mental well-being.
Good one.
Well, I think, yeah, everyone give a hand. Excellent panel. Excellent.
So we want to thank everyone that's on the panel for being up here. It's one thing for medical professionals to be up here and kind of voice their experience and share that with you all. It's another thing for a care partner to be up here. It shows a great deal of strength. So I'd like another round of applause for Cheryl. And one last time, thank you so much to a wonderful panel. And I think we have Sean coming up here, or maybe Will. But thank you a bunch again. It was wonderful being up here.
Okay, don't go anywhere. We're warming up the stock car races next door at Roseville. You're all going to get a ride. Everyone ready? It'd be a good fun time. Northern California, the winter is coming. The beanies are in the back. Get your favorite color, make a donation. Great product, so I have to do a little marketing for them. Before we leave today, I just want everyone to stop and say thank you to the awesome volunteers this year. I've never seen a group of volunteers run things so smoothly and do it so well for so many people. So I want to say thanks to the AV team over there, kind of hidden over the side. Great job, great visuals, great audio. And then to our event coordinators, Heather Tenfani and Georgia Fox Waters. Georgia's back here hiding. Heather's somewhere running around. Where are you? The best event planning team anywhere in the state. They took care of all this for PEG, 3 years running. Awesome job. So thank you. So what we want to do now is we have prizes. We have ways to say thank you and give out little prizes for things. So we have the drawing basket. We asked Jimmy Choi to do this. He said these papers are too heavy for him, so Cheryl's going to help. She's going to be the one to draw them. And so we're going to do that now. So Cheryl, pick what Kim Hawkins has folded these 3 times over, 4 times over like a card dealer. So they're all mixed up. And we have the first gift is 2 pair of walking sticks.
1 pair.
Oh.
There's 2 drawings. So first, we're drawing for a pair of walking sticks donated by the Nordic Walking Nation.
And that's why he's the executive director.
Okay. So letter pose. All right. So first off, Barbara Jones. Barbara?
Barbara, are you here?
Barbara, are you here? I didn't see that far. Yeah, you pull them out of there. Just yeah. Rochambeau.
You still win. No need to
be present?
No need to be present.
Change that? Okay, so Barbara, we'll go ahead and put this on there. And we'll, again, let's draw one more time. We have a second pair of walking sticks, also from Nordic Walking Nations. Peter Olson, O-H-L-S-O-N, right there.
Peter, way to go.
And you can pick up your prizes, I believe, at the pink table. So the next drawing is for one of 3 different wine baskets with paint glasses donated by Tom and Chico Castle. First, we have Gary Frey. Gary, there you go, Gary. Pink table for a basket of wine. Must be present to win.
Changing rules. Changing rules.
The boss said you must be present to win. Okay. We're going to shuffle that one. So we're drawing again for a basket with wine, paint glasses and wine from Tom and Chico. Is Angie Rooney? Angie Rooney here? Okay, let's go for the next. Joni Evans? Hey, Joni, you get a wine basket.
All right, Joni.
And we have one more, I believe. Yes. So, again, one more for a wine basket with paint glasses. This one is for Mary McKinley Cole. Mary McKinley Cole? Not here.
Keep looking.
Next. Leah Nisler. Leah?
Leah?
A wine basket. And now we're going for a 1.5 liter bottle of wine with some paint glasses, also from Tom and Chico. So we need 3 of those. Linda Wharton. Is there a Linda Wharton here? Oh, there you go, Linda. A bottle of wine and some paint glasses. And Kay Griffin. Kay also gets a bottle of wine and some paint glasses. Okay. Left. David.
Letouvrey.
L-E-F-E-B-V-R-E.
David.
David.
David L.
David L. All right.
All right, keep looking.
Mark Jones. Is Mark here? Okay. Wow.
See, you stay around long. Look what you get.
Sandra Evans. Sandra? Sil Nistler. Okay, that's for a bottle of wine and some paint glasses.
Put the sticker on it.
I forgot. Okay. We also have some gift baskets, some coffee gift baskets. And the winner of a coffee gift basket is Ann Barmer. Ann?
Ann Barner. And, oh, there's Ann right there.
There you go.
A great paint volunteer.
And Julie Roberts. Is there Julie Roberts? Not just me, okay. Irene Duggan, right there. Okay, coffee gift basket. That was the last time we turned the
All right,
page.
Irene.
All right, for a Rock Steady Boxing Warrior Fit $100 gift certificate, Mary Hoffenke. Mary? So close. Well, how about Donna Reed? Is Donna here? Hey, Donna, $100 gift certificate from Rocksteady. Yep. Kelly Ann
Rubulaba.
There you go, $100 gift certificate. And we got a copy of Dr. Ray Dorsey's book, Ending Parkinson's. Is Jennifer Westerby here? She sure is, right there.
Yay! See? Benefits of being a new board member.
And we have to go back. I do believe we have the, I think we did that. We have the walking stick of the person that's not here. So one more for a walking stick. And again, for the set of walking sticks, Roseanne Bogue.
Bogney.
Roseanne,
All right.
set of walking sticks. Go ahead to the pink table and they'll take care of you. And ladies and gentlemen, that's all we have for that. Thank you for coming today. A copy of the live stream will be available within the next week or so.
And just to remind everybody, October 22, 2022, Paint Conference will be open for business, and we're all going to be together. And all those in Zoom land, thank you so much for being here. And again, wanted to let people know on your way out, there is food to go. There are sandwiches and sodas and chips. Take what you want. It's good road food for you for staying late and being a part of the paint community. Thank you, everybody. Have a safe 2021-22. Great conference. Thank you.